Hi, and welcome to this updated lecture on history and physical examination of an obstetric patient. For this update, I also included how to calculate age of gestation and the estimated date of delivery. To download this lecture deck, please go to my WordPress site, Docina Obigaine. And here are the references for this lecture. So for the outline of this lecture, first, I tell you about the components of an obstetric history. Then next, I will teach you how to determine gravidity and parity, how to calculate fetal age of gestation, how to calculate estimated date of delivery using the Nagell's rule, and lastly, we discuss the components of an obstetric physical exam. So first, let's talk about pregnancy history. Obtaining an accurate obstetric history is very important to confirm a woman's suspicion of pregnancy, make accurate fetal dating, and assess the general health of the mother and her fetus. And obstetric history should be directed towards the risk factors that are known or suspected to diminish the health of either the woman or her developing fetus. And here are the components of an effective physician communication. First is you must be culturally sensitive if you're the physician, and you have to establish rapport with your patient, and you have to listen and respond to the woman's concerns, be non-judgmental, include both verbal and nonverbal communication, engage the patient in discussion and treatment options, and you convey comfort in discussing sensitive topics, abandon stereotypes, check for understanding of your explanations, and finally, show support by helping the woman to overcome barriers to care and compliance with treatment. So for the important components of an obstetric history, of course, we start with the socio-demographic details of the patient, and this will include, of course, her name, age, where she lives, her marital status, occupation, and her source of income. As for the chief complaint, usually, if this is just a prenatal checkup, then we put there regular prenatal checkup. However, some pregnant women may come in their clinic complaining of an abdominal pain or pelvic pain or a bloody or watery discharge. For the history of present pregnancy, so we include here when amenorrhea was noted, when assisted reproductive technique was performed, if ever ART was performed, or when pregnancy test was done. For the past medical or family medical history, it is important to note if patient has a history of chronic or genetic diseases such as diabetes mellitus, hypertension, chronic conditions, asthma, or other diseases. For the past obstetric history, ask the patient about her gravidity and parity, birth outcomes such as birth weight, gender, and major complications of pregnancy, labor or birth, history of premature birth or growth retarded infant, and etc. So we also ask her about personal or social history such as exposure to teratogenic chemicals or drugs, toxic substances. Ask her also about if she is smoking, if she has alcohol or illicit drug use. Of course, you have to ask her her menstrual history. Ask her about her last menstrual period and if her menses were regular. Also, her past surgical or gynecologic history, such as her history of OCP use or any history of gynecological infections. And of course, ask her also about her antenatal course, such as symptoms of pregnancy like nausea, vomiting, breast tenderness, pelvic pain, fatigue, change in urinary frequency, change in bowel habits. Also ask her if she has been taking folic acid, if there is already some lab test for screening, and other previous admissions during her pregnancy. So it is very important when determining the obstetric history that we determine or establish the patient's gravidity and parity, as I've already mentioned a few slides back. So we determine this or we record this by using the denotation G, P, and FPAL. Okay, so G here stands for gravidity. Gravidity means that this is the number of times that the woman has become pregnant, and this should include preterm births, ectopic pregnancies, molar pregnancies, and abortions. So not just the full-term births, okay? So P here will be parity. And the parity indicates the number of pregnancies that reach viable gestational age or pregnancy that reach more than 20 weeks AOG. And this should include the stillbirths. Okay, so for gravidity and parity, the number of fetuses does not determine the parity or the gravidity. And twin pregnancy that is carried to viable gestational age is only counted as one gravidity and one parity. Okay, so what does FPAL stand for? Okay, so the FPAL here will mean F stands for the number of full-term babies, P stands for the number of preterm babies, A is the number of abortions, ectopic pregnancy, or molar pregnancy, and L will be the number of living children. So let's see some examples so that you will understand this better. Okay, so the first example will be G1P0. This is also called a primigravid. And this means that the patient is on her first pregnancy. So for this case, we don't really need to denote the FPAL because this is just her first pregnancy. Okay, so the next example will be G3P22002. So this means that she has two previous full-term births, no preterm birth, no abortion, and two living children. So this denotation means that she is currently on her third pregnancy with two previous live-term births that are currently alive. Okay, so what about G3P22000? Okay, so this means that she has previous two full-term births, no preterm births, no abortion, no ectopic, no molar pregnancy. However, she has no living children. Okay, so this denotation of G3P22000 means that the patient is currently on her third pregnancy and she has two previous live term births but died thereafter. So she currently has no living children. The next example here will be G3P20202. So it means that 0, she has no full-term deliveries, and 2 means that she has a previous 2 preterm deliveries. 0 means that she has no abortion, no ectopic pregnancies, no molar pregnancies, and 2 here, the last number, will mean that she has two living children. So what does this mean? So it means that the patient is currently on her third pregnancy with two previous live preterm births that are both currently alive. Okay, so the next example, we have G2P10010. Okay, so 0 here will mean that she has no previous full-term delivery, no previous preterm delivery, one abortion or one ectopic or one molar pregnancy, and no living children. So G2P10010 would mean that the patient is currently on her second pregnancy and her first pregnancy was an abortion, or as I've said, it could be ectopic or a molar pregnancy. Okay, what about G2P22002? Okay, this would mean that the patient is not pregnant as of the moment, and she has two previous live-term births or two previous live-term pregnancies with both children currently alive. Okay. So what about if the patient is carrying multiple pregnancies or had a history of multiple pregnancies? Okay, so we have here a woman currently on her second pregnancy and had a previous twin pregnancy that was carried to term and currently alive. Okay, so how will you denote that? So, okay, so remember a few slides back, I told you that twin pregnancy or higher order multiple pregnancies will not be counted in the gravidity parity. So, one twin pregnancy would mean one gravidity and one parity. Okay, we will only count the multiple pregnancies in the FPAL denotation. So for this example, so we have G2P1 because this is her second pregnancy and she had a previous pregnancy that was carried to term. That's P1. So how do we denote a twin pregnancy in her history? So here, we have, instead of a 1001, so we'll denote that as 2002, meaning she has two babies that were full term, 0 meaning she has no preterm babies, no abortion, and she has two babies that are currently alive. Okay? So another example. So a woman who just gave birth to her twin babies on her first pregnancy. Okay, so we have a patient who is on her first pregnancy and then she gave birth to twins. Okay, so how will you denote that postpartum? Okay, so that will be G1, meaning because that was just her first pregnancy, P1. Okay, so we put in the twin babies here in the FPAL portion. So instead of G1, P1, 1001, if that were a singleton pregnancy, but since this is a multiple pregnancy, we denote it as G1P1 2002 because 2 would mean she has two babies in one pregnancy. All right? Okay, so here are some common terms that are used to describe parity. So a gravida means that a woman is pregnant. Primigravida means that a woman is on her first pregnancy. Another way of denoting this is a G1P0. Okay? Multigravida is a woman who has been pregnant more than once. Okay? Newly gravida is a woman who has never been pregnant. Okay? So we denote that as G0. Okay? Primipara or primipara is a woman who has given birth to only one child. That is meaning she has a history of giving birth to a child who may either be preterm or a term pregnancy for as long as that baby was more than 20 weeks AOG. Okay, multipara is a woman who has given birth more than once. Okay, as long as that baby was more than 20 weeks AOG. And nullipara is a woman who has never given birth or has never had a pregnancy that progressed beyond 20 weeks. Okay, next is I will teach you how to determine fetal age. Okay, so usually we do this by calculating the number of weeks of AOG based on the LMP or the last menstrual period. When you say last menstrual period, this will be the first day of the last normal menses of the patient. Okay? Now, it will be very difficult to calculate the fetal age if the patient doesn't remember her LMP or doesn't know her LMP. Okay? So, for cases like that, or if the patient has irregular menses. Okay? So, for patient who has irregular menses or does not remember her LMP, then you will resort to estimating the fetal age using uterine size, quickening, or first trimester ultrasound. So later during the physical exam portion of this lecture, I will tell you how to determine fetal age or to approximate fetal age using uterine size. Okay, so for now, I will teach you how to calculate the AOG or the age of gestation based on the LMP. Alright, so this is how we should calculate the fetal age of gestation. So suppose that we have a patient with an LMP or the last menstrual period at January 3, 2021. And let us suppose that the date today is May 1, 2021. Okay, so how do we calculate the fetal age of gestation? So first for January, that's 31 days minus 3 because this is January 3. We have 28. Okay, February, we have 28 days. March, we have 31 days. April, we have 30 days. And May, 1 day because we are supposing that the date today is May 1. Okay, so the total will be 118 days. Okay, remember, when you are asked to compute for the fetal age of gestation, you don't report this as the number of days. You should report it in terms of weeks and days. Okay, so how do we now convert 118 days into weeks? Okay, so we divide 118 by 7. Why 7? Because 1 week is composed of 7 days. Okay, so 118 divided by 7 will be 16 weeks and 6 days. Or 16, 6 over 7 weeks. Okay, so be careful. Do not report the AOG in terms of numbers with decimal places. That's wrong. When you report AOG, it should be a whole number and a fraction. Okay? Not in decimals. So, 118 divided by 7 will be 16, 6 over 7 weeks. Okay, next I will teach you how to calculate the estimated date of delivery or EDD. Okay, we usually use the Naegele's rule. Okay, so this is only used, so the Naegele's rule is only used only if the patient has regular menses and is sure of her LMP. Otherwise, you cannot use the Naegele's rule, as I've already mentioned a few slides back. So this is the formula for the Naegele's rule. So first, we add 7 days to the first day of the last menstrual period, and then subtract 3 months, then add 1 year. Okay, for example, let's say the LMP of the patient is July 5, 2016. Okay, so what will be the estimated date of delivery given this LMP? Okay, so first, July 5 plus 7 will be July 12. So July 12 minus 3 months is April 12 plus 1 year. So that will be April 12, 2017. And April 12, 2017 will be the estimated date of delivery or EDD for a patient with an LMP of July 5, 2016. Okay, now we go to obstetric physical exam. Now, when you do the physical exam of a pregnant patient, make sure to always provide comfort and a sense of privacy. Okay? Have the needed equipment readily at hand. Provide gown and drapes for abdominal and pelvic exam. Of course, this is for the patient's privacy. And instruct the patient, of course, to empty her bladder first prior to examination. And this is the best way to position your patient. Okay? This is in a semi-sitting position with the knees bent, supported by a pillow. And this affords the greatest comfort for the patient as well as protection from negative effects of the weight of the gravid uterus on abdominal organs and vessels. However, not all our clinics are equipped with this kind of bed. So most of the time, we just make do with a bed that has affords the patient to lie down straight on her back. So what would be the important equipment when doing physical exam of a pregnant woman? Actually, there's not a lot, okay? So the examiner's hands are actually the primary equipment for examination of a pregnant woman, and you should always warm your hands, okay? And avoid tender areas of the body until the end of examination. Of course, you also need a speculum, a tape measure, and a stethoscope or a fetal Doppler. Okay, for the general examination, you inspect the appearance of the patient, the overall appearance of the patient. So you can note here the overall health status of the patient, the nutritional status of the patient, emotional state of the patient, or her neuromuscular coordination. Also, it's very important you determine her weight, height, and calculate for the BMI. And of course, it's very important also that you determine the vital signs like the blood pressure, pulse rate, and temperature. Very peculiar among pregnant women will be the skin pigmentation changes, especially in the head and neck and even the abdominal area. Okay, for the head and neck area, you will note or you might note cloasma or melasma gravidarum, and these are the irregular brownish patches of varying size that appear on the face and the neck of a pregnant woman, and this is also called the mask of pregnancy. So for the hair, note the texture, moisture, and distribution of the hair. See if there's any dryness, oiliness, or minor generalized hair loss. Okay, so for the eyes, of course, it's very important that you look for signs of anemia. Okay, for the nose, nasal congestion is common among pregnant women, and nose beads may also be common. For the mouth, inspect the gums and the teeth, and gingival enlargement with bleeding is sometimes very common. And thyroid, note for symmetrical enlargement, because some degree of symmetrical enlargement may be expected, but marked enlargement is not normal during pregnancy. For the thorax and the lungs, inspect the thorax for pattern of breathing. There are usually no abnormal physical signs except some women who might experience labored breathing. For the heart, palpate the apical impulse. In advanced pregnancy, it may be slightly higher than normal because of the dextrorotation of the heart due to the higher diaphragm. And also auscultate the heart, of course. And you will note that there are soft blowing murmurs, okay? And because this reflect the increased blood flow in normal vessels. Inspect the breast and nipple for symmetry and color, and nipples and areola become bigger and darker, and the Montgomery glands of the areola become prominent. You can slightly compress the nipples with finger and thumb if the patient allows you to do so, and you might be able to express colostrum from the nipples. Okay, for the abdomen, you might also note some skin changes or some discoloration, such as linea nigra. So the linea nigra is this one, this line here in the middle, and this is the darkening of the linea alba, okay, which is the midline of the abdominal skin from the xiphoid up to the symphysis pubis. And this is due to the stimulation of the melanophores by increase in the melanocyte stimulating hormone. Another very common abdominal changes that you see will be striae gravidarum or the stretch marks. And this is because of the separation of the underlying collagen tissue secondary to the stretching of the abdomen, and they appear as irregular scars. Okay, during pregnancy, they appear as reddish or purplish, but postpartum, you will note that this stretch marks or striae gravidarum will become silvery. Okay, occasionally the muscles of the abdominal walls do not withstand the tension to which they are subjected, and as a result, the rectus muscles separate in the midline, such as this picture here, and this is what you call diastasis recti. Now, if severe, a considerable portion of the anterior uterine wall is covered by only a layer of the skin or attenuated fascia and peritoneum to form a ventral hernia. Another skin pigmentation changes is the spider telangiectasia, such as you see here in this picture. And these are vascular stellate marks that result from very high levels of estrogen. This blanch, when pressure is applied. And palmar erythema is also an associated sign. And this typically is seen in the face, neck, and upper chest and arms of the patient. Okay, so remember a few slides back, I told you that one of the ways by which we can approximate fetal age, especially if the woman does not know her LMP or if she has irregular menses, no, one of the ways by which we can approximate fetal age is by abdominal exam. Okay, so one is by palpating the fundus of the uterus. Okay, if you palpate the fundus of the uterus at around the symphysis pubis, that would mean that the fetal age will be around 12 weeks AOG. Okay? If you palpate it at around the umbilical level, here, that would mean that the fetal age is around or approximately 20 weeks AOG. If you palpate the uterine fundus midway between the symphysis pubis and the umbilicus, then that would mean that the fetal age is approximately 16 weeks AOG. So another way of approximating fetal age by abdominal exam is by determining the fundic height, such as you see here in this picture below. Okay, so how do you do the fundic height? So as you can see here, we need a tape measure. And with the use of a tape measure, you have to use the centimeters part, not the inches. Okay, so how do you do this? First, you have to place one end of the tape measure in the symphysis pubis and then carry it over the abdomen of the patient until you reach the uterine fundus. So whatever measurement in centimeters that you get from the fundic height will be the approximate fetal age. Okay, and there's good correlation when the patient is between 16 to 32 weeks AOG. So for example, you get an fundic height of 20 centimeters, and so that would mean that the approximate fetal age will be 20 weeks AOG. Okay, so for palpation of the abdomen, you might perceive fetal movement. Okay, so examiner may feel fetal movement after 24 weeks AOG. However, the fetal movement may be felt by the mother around 18 weeks, and this is what you call quickening. Okay, you might also feel uterine contractility. No, the abdomen may feel tense or firm to the examiner, especially if the patient is in labor or when the patient is experiencing Braxton Hicks contractions. Some fetal parts may also become palpable, especially if the mother is not obese. Okay, so for the palpation, we also have what we call the Leopold's maneuver. And this is an abdominal exam to determine the fetal presentation. Okay, for Leopold's maneuver 1, this is what we call the fundal grip. Okay, for this maneuver, we will put both our hands in the fundal area. Okay, so we palpate the fundal area or the uterine fundus to determine which fetal part occupies the fundus. Okay, the fetal head should be round and hard and ballotable. And if we feel for the fetal breech, such as you see here in this picture, then this will feel like a large nodular mass. Leopold's maneuver 2 or LM2 is the umbilical grip. And here, we palpate the para-umbilical areas or the sides of the uterus. And we do this because we want to determine which side is the fetal back. Okay, why do we need to know or determine which side is the fetal back? Because that would be the area where we can hear the fetal heart rate or fetal heartbeat best. Okay, so a fetal back would feel like a hard resistant convex structure, whereas the fetal parts would feel nodular and irregular. Leopold's maneuver 3 or LM3 will be Paulick's grip. Okay, so this will be the suprapubic palpation using the thumb and the fingers just above the symphysis pubis to determine fetal presentation and station. In other words, you do this maneuver to know which fetal part is nearest the birth canal. Okay, so in this case, the fetal part that is nearest the birth canal will be the fetal head or what we call cephalic presentation. And lastly, we have Leopold's maneuver 4 or LM4. So this is what we call the pelvic grip. So Leopold's maneuver 4 is the only maneuver where the examiner will face the patient's feet, because in the previous 3 maneuvers, the examiner is facing the patient's head. So at this point, the patient or the examiner will face the patient's feet. And so, the examiner will palpate the bilateral lower quadrants to determine engagement of the fetal presenting part. If the fetal part is already engaged, then the examiner's hands, such as so, will diverge. Okay? So, if the fetal head is not yet engaged, then the examiner's hand will converge in the middle. Leopold's maneuver 4 will also allow us to determine the fetal attitude. Okay, so if you feel the fetal head on the same side of the fetal small part, such as in this picture, it means that the fetal head is well flexed. However, if you feel the fetal head on the same side as the fetal back, then it means that the fetal head is extended. Okay, so of course, when we examine the abdomen, we have to auscultate the fetal heartbeat. Okay, so again, no, we will know the best area to put or to place our stethoscope or our fetal Doppler by doing the Leopold's maneuver 2. You have to determine the fetal back or where the fetal back is. Is it the maternal left or the maternal right? Or the upper quadrant or the lower quadrant? Okay, once you've determined where the fetal back is, then you place your stethoscope, the bell of the stethoscope, or your fetal Doppler over that area. Okay, so the fetal heart rate is usually at a range of 110 to 160 beats per minute. Okay, so this is detected through a stethoscope or using a stethoscope at 18 weeks AOG. However, when you do you use the fetal Doppler, you can detect fetal heartbeat earlier at 10 to 12 weeks AOG. Okay, also examine the extremities of the mother. So inspect the hands and legs. Usually they might show edema. Palpate for pretibial ankle and pedal edema. Physiologic edema is more common in advanced pregnancy and in women who stand a lot. And pathologic edema is often grade 3 plus and often associated with pregnancy-induced hypertension or preeclampsia. and also check for leg varicosities. For the genitalia, of course, you have to note the hair distribution, the color, or if there are any scars in the genitalia. Note for the parous relaxation of the introitus and any noticeable enlargement of the labia and clitoris. And note for scars from previous episiotomy or perineal lacerations. Inspect the anal area for varicosities or hemorrhoids. Palpate the Bartholin's and skin glands. And check for cystocele or rectocele. Okay, so for the vagina and the cervix, we usually note some color changes, and this is what we call Chadwick sign. Okay, so the Chadwick sign means that the vaginal mucosa and even the cervix becomes congested and violaceous. No, it becomes. Why does it become violaceous? Because of the increase in the blood vessels and blood flow around this area. So it becomes violaceous or bluish or purplish in color. Cervical glands may undergo marked proliferation, and by the end of pregnancy, they occupy up to 1/2 of the entire cervical mass. Okay, so as you can see here, no, this is what you call marked proliferation of the cervical glands. And this normal pregnancy-induced changes represent an extension or eversion of the proliferating columnar and the cervical glands. Okay, take note also when you're doing a speculum exam, if there are any vaginal discharge, maybe watery, whitish, foul-smelling, curd-like, bloody, etc. Or if there are any lesions such as warts or foreign body or tumorous growths. Okay, we can do also by manual or internal exam. So for the Heger sign, this is the sign where there's softening of the uterine isthmus, resulting in its compressibility on bimanual exam. And this will be observed by the 6 to 8 week AOG. Now, the Goodell sign is the cyanosis and softening of the cervix, and this may occur as early as 4 weeks AOG. Okay, so also we have to do internal exam, no? We have to estimate the length of the cervix by palpating the lateral surface of the cervix from the cervical tip to the lateral fornix. Okay, so this is determining the effacement. Okay, so not only the effacement, we also have to determine the dilatation. Okay. Now, for internal exam, note, as I've already mentioned, note if the cervix is closed or dilated. And if dilated, take note of the following. Estimate the approximate size of dilatation in centimeters. Note the fetal station. Note the fetal presenting part, whether it's cephalic or breech, or is the bag of waters intact. Now, finally, we have to conclude the visit. Okay, we have to end our examination. Now, once the examination is completed, instruct the patient to get dressed. Review the findings with your patient once she's ready and dressed, and answer, of course, all your patient's questions or queries or any concerns. Advise necessary laboratory or ancillary procedures the patient might need. Reinforce the importance of regular prenatal checkups, and of course, it's very important that you record all your findings in the patient chart. So, in summary, we've discussed components of an obstetric history, and I've already taught you how to determine the gravidity and parity of the patient, how to calculate the fetal age of gestation, and how to calculate estimated date of delivery. And finally, I also discussed components of an obstetric physical exam. Okay, that's it for my lecture, and thank you for watching this lecture in YouTube. And please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigayne. Thank you.